Hey there and welcome. My name is Carmen. I am a myofunctional therapist and I am also a myofunctional educator, which means I spend tons and tons and tons of time educating my audience or people just like you. So it only seemed normal when my team and I were looking to decide about our goals for 2019. It only seemed natural that we really dialed down on educating and engaging with our audience to make sure that we're giving you the information that you want to learn or we're answering your questions. So we decided that we would do that engagement by doing more of our Facebook Lives, or more of by introducing them. So this is our first Facebook Live in this platform, and hopefully it goes off without a hitch. You never know how technology is going to be. You are certainly welcome to ask questions, to make posts. There is a little bit of a delay. So if you ask a question and I don't immediately answer it, it might be because I haven't seen it yet. Or it could be that your question is way too specific. And so that would be something to directly message me about. I will entertain questions if they are in regards to the questions that we're going to talk about today, just so that it's not so specific that it's not useful to somebody. I do want to make sure that all questions get answered. So if I miss it or I overlook it, make sure to post it in the comments again so that I can make sure and answer that for you. So our topic for today is going to be moving from curious to confident in under 5 minutes. And the reason that I can really say in under 5 minutes is because if you use the myofunctional assessment tool that we're going to talk about, that will help you understand if you have things that would be concerning to make sense to move on to a myofunctional exam. So a lot of dental offices use this tool that I have created for them as a screening tool, so that it doesn't make any sense to refer somebody to a specialist if they don't know where they have impairment. So we're going to talk about that, and I'm going to dive a little bit deeper into those questions so that you know, why does Carmen ask these questions about ear infections, or why does she care whether I was breastfed or bottle fed? Those are things that matter, and so I'm going to talk about that today so you can get a little bit more of an understanding. Now, then after that point, you'll be able to confidently know whether you should move forward with a comprehensive exam or not. So, and we'll talk about that a little bit later too as we go. So let's jump into this assessment form. So you can download this. At the end, we'll talk about it some more, but some of you have already been able to access this. So this tool, there is an adult assessment form and there's a child assessment form. It's really the same thing. It's just worded a little bit different so that you as a parent can say, oh yeah, Johnny does have these problems, or I have these problems. So I'm going to answer, or I'm going to talk about these questions. They're not really specific to whether it's an adult or a child. Okay, and I'm not going to cover all of them, just some of the most common ones that people have more questions about. So when I am doing a comprehensive exam with somebody, I am trying to figure out two things. Do they have a tongue tie? And do they have myofunctional impairment? So that myofunctional impairment is really the most important stuff. That's really, the tongue tie is just a piece of it. It's an important piece, but it's just a piece of it. So when I'm doing a comprehensive exam, I'm trying to either figure out if they have one, or I'm trying to support what I already know. So let's face it, some people have an obvious tongue tie. I mean, people can open their mouth and I can see it. And while we never diagnose it based on appearance, some of it, some are very obvious. So in that case, when I'm doing a comprehensive exam, I'm helping the client connect the dots back to, this might be why you had trouble nursing, or this might be why you had trouble with ear infection. So it's my job as I go through that comprehensive exam to help those people understand all of their symptoms. Okay, so let's get started with the questions. So first, let's talk about the breastfed or bottle fed issue. The reason I ask this question is because I'm wanting to try and dig a little bit deeper. I'm trying to figure out if somebody was bottle fed because they couldn't breastfeed because they had a tongue tie, or were they bottle fed because that's just what mom did? So I ask those questions. When an infant is breastfed, they are essentially doing myofunctional therapy. That is helping develop the muscles of the mouth and face. So when that happens, those children may or may not have issues if they have a tongue tie. So when I ask somebody whether they were breastfed or bottle fed, I'm digging a little bit deeper. What I also want to know, if somebody tells me, or say you answer that question and you say, I breastfed and I didn't have any issues. I ate all the time. I would fall asleep while breastfeeding. You know, I was pretty content. For me, as a myofunctional therapist, I'm screening those answers and I'm already saying, okay, red flag, because in an infant who nurses all the time, that's because you're not getting full, you're not getting satisfied each time. So when I talk with people about that and I can explain, the reason that you fall asleep while you were nursing is because it was exhausting. So an infant that has a tongue tie, it is work, because breastfeeding in and of itself is difficult, and then they have a nap and then they're not full, so they eat some more. So it's a very vicious cycle. Another area that I'm collecting information about is, you know, I asked the person, tell me a little bit about you as an infant. Were you happy, sad? Did you spit up a lot? Did you have colic? Did your parents medicate you for acid reflux? Did they have to prop you up in the corner of the crib? Those seem like really weird questions. However, it's helping me understand. So when somebody tells me that mom and dad had to prop them in the corner of the crib, I know there's a concern, you know, or when somebody says, I was medicated for acid reflux when I was 6 days old. Again, there's a reason there. One other thing I want to touch on here before I move on is the question about ear infections. So when I ask you, or when you see the question on the assessment form, and it's asking you about ear infections, and you tell me, oh my gosh, yes, I had multiple ear infections, and I had, you know, 4 sets of tubes, that is telling me, okay, something is going on here with the swallow. So we know that in somebody, an infant with a tongue tie, that there is dysfunction in the swallow. Now, you as an adult may have no idea that you don't swallow right, because you don't know it's broken. So you think you're fine. Clearly, none of us have starved. But you started swallowing wrong all the way back to about 20 weeks in utero. So that's just how it is. When a proper swallow is done, the tongue goes in a nice wave. So when we have an adequate swallow, generally the eustachian tubes drain properly. So if you swallowed and you can hear a click, that's your eustachian tubes draining. So when we have somebody who doesn't swallow properly, oftentimes we see a connection to ear infections. Now, not always, it's not 100%, but it's very, very common. So I use that information about how an infant was fed, if you breastfed, if you had troubles, is there failure to thrive issues? And the reason that we ask about failure to thrive is because some babies might not know that there are nursing issues, because they're just living on the letdown reflex. So they're basically being force fed by their mom. So their weight will grow, and then eventually it will start to decline, and they can't figure it out why. So a lot of people, when I do a comprehensive exam, they're really, really surprised at how this stuff connects. Okay, next, let's jump down to talk about tonsils. This is another area where there just isn't a lot of education. So people have tonsils taken out oftentimes because maybe there was a problem with snoring, it was causing mouth breathing, you know, that type of reason. But what happens is when you remove the obstacle, you don't remove the habit that went along with it. So maybe little Johnny used to snore really bad, he had some sleep apnea as a child, they took out his tonsils, but what has been done for the habit now? So when you consider the 4 goals of myofunctional therapy, are that the person is nasal breathing, that they have correct tongue posture, they have correct mouth posture, and their swallow is correct, you can see that, okay, well, if somebody had their tonsils out, I want to know more about that habit. So that's how that question relates. That also kind of connects to the next question on the assessment form about, is mouth open at rest? So I just mentioned the proper mouth posture, and that is mouth closed, lips sealed. So we don't want open mouth resting posture that can create changes to our craniofacial growth in children, and it creates like a long, narrow jawline, or a vertical jawline for adults. So I can look around at people and kind of have an idea whether they were mouth breathing or not, and had an open mouth resting posture. So that's why I ask about those things. The important thing that I am doing as a therapist is I'm trying to figure out if this person can nasal breathe, because it makes no sense for me to be doing myofunctional therapy with somebody who has a physical reason that they can't nasal breathe. So if you can nasal breathe for 1 minute, you can do it for life. It's not easy, and we have to work through the processes to get you there. One of those big problems is chronic congestion, so we have to work through that. But we want to make sure that you can nasal breathe. Now, interestingly enough, there are a lot of people who will have nasal surgery, they'll have a deviated septum fix, that kind of stuff. Nobody ever tells them that they need to be nasal breathing. So that is a disruption in the communication, which eventually, hopefully, we get some more communication on that. But these people, they don't know. So that's why on this assessment form, I'm asking those screening questions, because if you had something fixed, did you correct the habit that you had created? Because we are born nasal breathers, so the mouth breathing habit, something happens. And generally, maybe it's sickness, maybe it's those tonsils, whatever, we switch over and we might, like I said, remove that obstacle, but we don't correct the habit. So let me touch on chronic congestion here for a minute, because one of the questions on the assessment form talks about medicines, and chronic congestion with my clients is a huge problem. So when people mouth breathe, they just get thrown into this cycle of chronic congestion. And really, in a nutshell, it's because our body wants to keep oxygen, carbon dioxide, all of that stuff level. So if you're mouth breathing, your body thinks, whoa, wait a second, you're letting too much CO2 out, which makes your body want to clog up the nose, because your mind basically thinks you can only breathe one way, which is nasally, because that's how we were designed to do it. So when somebody is mouth breathing, their body is clogging up their nose, which is creating it to be harder to mouth breathe. So very vicious cycle. You have to break that cycle. First, that means that we have to make sure that you can nasal breathe. And then after that, we look at things that start working on that congestion. My own experience was I used to take 4 allergy meds a day, 4, to deal with my chronic congestion, because I was a mouth breather. So I was in that vicious cycle. The other thing that is important is like an inflammatory diet, dairy, that kind of stuff. But when I'm working with my clients, if they say, well, I'm congested, but dairy causes congestion, we really need to deal with the pink elephant in the room, which is the mouth breathing. But if they know that dairy causes congestion, then we need to eliminate that too. So an inflammatory diet can make it worse. But first, I want to tackle that breathing issue. Okay, so we've talked about a lot of things. Now I'm going to jump down to talking about tongue resting posture. I get this question a lot on why does it matter where our tongue is? So, and really, why does it matter where my tongue is as an adult? Because as a child, we want that tongue in the roof of the mouth to help spread that maxilla out, because it's like wax. So it's going to bring down the ceiling of the palate, and it's going to spread the arch out. So adults will say, well, why does it matter to me as an adult? So really, if you transition into adulthood, why I would tell you that the proper tongue position, which is the tongue, tip to tail, so I want the whole tongue in the roof of the mouth, is to support the airway. And so when the back of the tongue is up, that supports the airway and can help with snoring, sleep apnea, those type of things. So the proper tongue position is important. The other thing is try and nasal breathe when you have your tongue in the floor of your mouth. It's a little bit difficult. So those are things that we work on. A lot of people have no idea. So if somebody has a tongue tie, their tongue is pinned down. So it's a physical barrier. They can't get it up there. A lot of my tongue-tied clients have never felt the real estate in the roof of their mouth. So we eventually changed that. But when we start, they have no idea why that even matters. Next, we'll talk about tongue thrust. So really, it's worse where your tongue lays, so that constant force is actually worse than a swallow. But again, my own experience. So I had a really strong tongue thrust, and I would pay for braces, have these nice, beautiful straight teeth, and then I would swallow. And so as I swallowed, I was pushing my teeth out. So I was causing them to flare because my swallow was coming forward and down rather than up and back like we want it to be in that nice wave. So on the third orthodontist, because of course I kept switching orthodontists because I thought they were doing a terrible job, my third orthodontist said, I'm happy to take your money, but if you fixed how you did things, you could correct your tongue thrust. So the tongue thrust is a problem. It causes ortho to relapse. It causes a lot of digestive issues. And it's really important to fix so that long-term, the swallowing issues are not a problem. So I like to tie tongue thrust into a conversation about digestive issues for a minute. Many of my clients come to me with digestive issues, and they have a really strong tongue thrust. So when people swallow improperly, they can swallow air, aerophagia, which causes belching, hiccuping, bloating, gas, that kind of stuff. But more importantly, when I'm digging for more information with my clients with digestive issues, first of all, they don't understand how this has how there's any connection. How can having a tongue tie have any connection to the fact that I always have a stomach ache? So it's always nice to be able to educate them and tell them, well, when you have a tongue tie, we've already established that you don't swallow right. Very often when somebody has a tongue tie, they don't chew their food either. So they tend to be very rapid eaters and they swallow a bunch of air, but oftentimes they swallow half-chewed food. Ideally, you're supposed to chew bilaterally, which is on both sides. You're supposed to use the tongue as a tool to help manipulate that food into what's called a bolus, which is what you actually swallow. And so when the tongue is tied down or has no muscle tone, it can't do that properly. Children take the path of least resistance. So children will they'll request smoothies, applesauce, chicken nuggets. I've actually had adults in, middle age that make their decisions of what they're going to eat based on how easy it is to chew, because chewing with a tongue tie is very exhausting and it's difficult. What happens when those clients get older and they never deal with the issue is now suddenly I have an influx of clients who have choking issues. So that helps explain the digestive issues. Also, if you think about digestive issues and not chewing properly and all of that stuff, where does acid reflux come in? One of my biggest and most successful cases that I have done with a preteen who had severe acid reflux. She had been medicated all of her life, and really not only was she taking a prescription medication, she was taking a bunch of antacids every day. And really, mom only wanted her to get off the antacids. And so this person was sent to me as a tongue thrust case from an orthodontist, and he had no idea that there were concerns as far as digestion. And so sometimes the digestive stuff takes a while, especially in somebody who has a really strong tongue thrust. But I started with her like in the summertime, I think about July or August, and it took until December, slowly but surely, as she learned how to use her tongue properly, her digestive issues went away. And so not only did we get rid of the antacids, but we got rid of the prescription medication too. So there is a huge digestive component. And I tell all of my clients, you will slow down eating. And if you have digestive issues that are related to myofunctional impairment, you're going to have improvement. Now, if you take a medicine that a side effect is a stomach ache, then clearly we're not going to solve that. But if it is related to your habits, we're going to see improvement there. Okay, so I'm going to jump down to the obvious one. You know, has anybody ever told you that you are tongue-tied? So a lot of what I do is screening for those elusive tongue ties, meaning those people who have a tongue tie and they've compensated very well. There are different grades of a tongue tie, so they're not all the same. The restriction is not all the same. So what I have found is that if somebody has told you that you have a tongue tie, then it's probably a pretty significant one, because that's an area that there's not a lot of education about. So it's worth being concerned about and thinking about. Now, when we talk about trouble with speech, some schools of thought say, well, you only need to do something about a tongue tie if you have a speech impediment, or some say you only have to do something about a tongue tie if it only hurts when you lick an ice cream cone. So first of all, those are very, very close-minded, one way of thinking that makes it really hard. That's why education in this field is so important. So oftentimes, a lot of my clients have come to me and they have had a history of failed speech therapy. And really, it's because they were never going to get better with that speech until their tongue was released out of the floor of their mouth. So some acoustic sounds, some things with speech, which myofunctional therapists do not do speech therapy, but it takes a team of this. And so a great example, my granddaughter had a tongue tie, had failed speech therapy, and the two really kind of went hand in hand. So once we identified her tongue tie, got her released, now she's moving along successfully in speech therapy, which really makes sense. So not everybody has to have speech concerns. A lot of my clients have problems like if they have a glass of wine or they talk all day, they're exhausted. Because again, if you have a tongue tie and you're talking against that, it's like stretching a rubber band over and over and over and over. It's exhausting. There are also social implications of having a tongue tie and not knowing it. A lot of people who have a tongue tie, talking is work. So they're kind of shy, they're reserved, they're not loud and boisterous. You know, they don't get their words out very easy. So some of those people will say, I'm shy, or maybe people call me antisocial. So those things sometimes are what makes somebody think maybe they have some concerns. Okay, so a last couple things here. Let's talk about chronic headaches, neck, shoulder tension, that kind of stuff. I don't get a lot of this from children because they just don't know. So they just don't complain yet about it. It is one of the most successful symptoms that are helped in having a frenectomy done. So I never like to sound like a snake oil salesman or a used car salesman, anything like that. But this is one of those areas when I have somebody come to me and they say, oh, I just feel like this, Carmen, all the time. A lot of that has to do with being tongue-tied. So when people, when they understand that, you know, being tongue-tied, they're rolled forward, oftentimes they're compressing their diaphragm, so they're not breathing effectively, they're not breathing well. Once they have that release, then they can start to improve in their posture, improve in their tension, many other things. So again, it's a piece of the puzzle, it's a process, but dealing with the tongue tie is really the first part. So that's part of that screening is if you have always your whole life had tension headaches. Now we're not talking migraines because that's different. Migraines can be caused by so many different things. So I never tell somebody they're going to have relief from a migraine. If they do, cool, we love that. But unless their migraine comes from structural misalignment, we're really going to be missing the boat on that one. Let's see, what else here did I want to talk about? Let's kind of end with sleep. Quality of sleep, clenching and grinding. So a lot of clients clench and grind. that first and foremost, when I'm doing a comprehensive exam, is me screening to see if you have sleep disordered breathing concerns. Because I tell my clients, really all I am doing through a comprehensive exam is I am looking to pass the buck. And by pass the buck, I mean I'm going to send you to your doctor so they can make sure that you don't have sleep apnea. Open mouth breathing, snoring, upper airway resistance syndrome, and sleep apnea are kind of the different levels of sleep disordered breathing, and none of them are healthy. Not at any point is any mouth breathing, snoring, any of that stuff healthy for you. Upper airway resistance syndrome, UARS, and obstructive sleep apnea are very, very, very debilitating, degenerative diseases. So it is my job to help you understand and to determine if you need to see somebody for that. So that's why I ask all the different sleep questions, because if you're coming to me and you're saying, I snore, I don't wake rested, I'm grinding my teeth. Grinding is very often your body's 911 call. So it's not just annoying to the person sleeping next to you, or it's not just annoying to your dental work. It could be your body saying, hey, this is my distress call. So those are the things that we're screening for. Really, if you were to look at the things on the assessment form, those that relate to sleep are the ones that I would tell you to take with the most serious approach, because that is the biggest thing. I tell people repeatedly, I do what I do because sleep apnea kills people. And so everything that I do and educate along this continuum is for prevention of sleep apnea. Okay, so I think I've given you guys a bunch of information about the screening. So now what? So now if you've used this assessment tool, or you've kind of listened to this and some of the things I've talked about, they resonate with you, now what do you do? I tell you that at this point, once you have moved from being curious about your myofunctional impairment to being confident and knowing that you have a concern, you don't understand all of it now. So you still need a little bit more support, and you need that person to guide you, and you need an exam. So whether it's with me, anybody else, now is the point where I encourage you to have a comprehensive myofunctional exam. A couple things, because that person is going to help you connect the dots. I tell people when I start their exam, my goal is by the end that you have no questions. That means I have done my job. You understand the connection, you understand your symptoms, you understand your impairment, and I'm good if you don't have any questions. So also, when you do that, when you find somebody to work with, you are finding somebody who you like, who you can trust, who you trust their judgment, because they're going to guide you. There is so many opinions and stories and anecdotal stories, all of that stuff out there. Everybody is getting their research and information from a lot of different sources, and sometimes those sources aren't necessarily the best place to get that. So when you have a comprehensive exam, this is going to be the person that's going to help you move along that path towards wellness, towards solving what is going on. So that would be your next step. If you've taken the assessment, you know you have concerns. If I have a mom and a child and they both have concerns, and mom is saying, so what do I do first? The child. We definitely want to get our hands on that kiddo, because for a number of different reasons, but that kiddo is in that window for growth, and we want to be able to get the mouth closed, get nasal breathing, get the tongue up, and facilitate proper facial growth. So maybe we can prevent things down the road. So there's important reasons for adults, but if you are a parent of a child who does this assessment form and has concerns, I want the adult to take the back seat and let the child get the help. Okay, so last, if you do not have the assessment form that I have been talking about, you can get that on my blog, and that is Myofunctional Therapy for You, and that is the number 4, the letter U.com /blog, or you can find it in the Facebook posting. So we have that there. With that said, I will see you guys next time. Bye for now.